shall now go on to our next speaker, Dr. Vikas Mittal, who is the founder of the LJI Institute, Ambala, who's a corneal and laser vision correction center. And he is going to be talking on corneal tissue additive procedures in keratoconus management. On to you, Dr. Vikas.
Yeah, thank you so much, Dr. Chitra, for this opportunity. And it's a lovely session going on. So from surface, we'll go slightly down. We'll see that how best we can add tissue in the cornea. Okay, so I'll start with a case. This 20-year-old boy who had a progressive keratoconus came for consultation in the right eye, had undergone transplant in left eye 3 years back. He was not very happy with the vision, mainly because of astigmatism, and in both eyes with contact lenses, the vision was fine. This was the tomography. You can see that K was more than 65 diopters and pachymetry was close to 300 odd microns. So what options do we have? He has good vision with contact lenses and the pachy is 300 microns. We want to stabilize if possible because he can use contact lenses. But how we can stabilize this? Cross-linking and 300 microns will be very challenging and patient didn't want to do, any DLK or PKP. Is there anything else? So these are the kind of patients where the thought process of cornea tissue additive procedures came in. And let's go through what all have been described so far. It started with Dr. Mellis describing Bowman layer, only Bowman layer going inside the cornea. And the reason, the rationale was in keratoconus, you have a fragmented Bowman layer. So the support is lost. So if you place a Bowman layer in the stroma, it might cause the stabilization of keratoconus. And they have, more than 5-7 follow and found with Bowman layer as an additive procedure is the stabilization of. The challenge is that the surgery per se is challenging, is sometimes challenging, and that's why most of these reports are from single center. Is there anything else? There are, more than half a dozen articles on use of smile lenticule. The smile lenticule that we remove from a myopic refractive surgery can be placed inside the mid-stroma of the cornea. Here again, they have found that it gets accepted pretty well, and there is a stabilization of keratoconus when we transplant the smile lenticule into the cornea. Here, we would be dependent on a specific femtolaser, which can cause, from where you can do a smile, and then there'll be no Bowman layer in this lenticule. So what we did was we tried to use both Bowman layer as well as corneal stroma as an additive procedure to strengthen the keratoconus cornea. So how you do it is just remove using femtosecond laser, harvest anterior 180 to 200 microns from a optically clear donor cornea, and using femtosecond laser, create a pocket in the recipient cornea, and then place this inlay inside this pocket. Because it has both Bowman layer and anterior stroma, and it is placed intrastromally with Bowman stromal inlay. Let's go through this video to see what exactly is done. So this is the patient eye. So first patient eye is dog. We are planning 9.5 to 9.8 diameter of intrastromal pocket. You can, change your, even LASIK software can be used to create this pocket. After the patient eye is done, now you mount this artificial donor cornea on the artificial anterior chamber. And plan was to create 180 to 200 odd microns anterior stromal graft. First epithelium is removed using alcohol. The limbus is marked, and then routine docking is done. So we need to ensure that your this inlay is within those marked areas. Once it is marked, you can remove this, and this harvested is stored in BSS. Now the patient is taken into main OR, and the pocket which has already been created can be opened with any blunt instrument. As you can see here, just like those smile instruments also, with that also you can open it. It opens pretty well. Now the inlay is loaded onto the routine IOL injector with Bowman layer side up, and then this will be injected into this pocket, and it goes pretty easily. The feel here is, and this once it goes inside, you can open it using any cannula, and centration can also be done by a surface massage. The feel is more or less similar to what we see after DSAC, the unfolding and then straightening or centration. And once you do this, you don't need to suture anything. and the surgery is over. So there is a tissue additive procedure. We have transplanted bone layer and angiostoma into the patient's keratoconus eye. Generally, first week is slight edema, but it's settled down within 1 month time. And after 1 month, it's hardly visible, although we have two interfaces. You can see the same patient. Just look at this pachymetry map here, 300 microns to it has become 500 plus microns. So we had reported first 10 eyes in JCRS, where we found that it is surgically very easy, no specific surgical skills or specific learning curves. Anyone who's comfortable with LASIK can do it. No specific intracorneal. We didn't see any folds or interface haze during follow-up anytime. Increase in pachymetry is very predictable, and posterior float as well as keratometry remains stable. And few of these patients are more than I think 3.5 years follow-up, and they all are very stable. The keratoconus is stable. Vision was more or less same as it was pre-operative. There were change in tomographic parameters, but these were not statistically significant. This boy, we had done one eye Bowman stromal inlay and other eye cross-linking, and we found that over a period of now it's 3 years, the both eyes are stable. So it was head-to-head comparison, and then we compiled our 5 patients which have been followed for 20 months, and what we found was both eyes were stable. So that means the BSI efficacy in stabilization of keratoconus seems to be equal to what we have a gold standard collagen cross-linking, and the Kmax tends to decrease in BSI, and pachymetry, of course, will increase in BSI or additive procedure. So as I said that, tomographic parameters doesn't change much. So we thought that maybe we can customize the shape of this inlay to achieve a lower or flattening of cornea. So what we can do here is, on the stromal side, you can ablate it, make it a negative meniscus inlay, and then you implant it into the mid-stroma of the cornea. So there you may achieve a central flattening. So I'll just go through this video. So here, same what we have shown you. So after harvesting of this inlay, this is flipped. So it's flipped. Now the stromal side is up and Bowman side is down. And this whole thing is shifted onto the excimer laser, and the center 70 odd microns, we have done a PTK. So overall it was 8.25, and the center 4 mm, there was a PTK. And then you can see the post-operatively, it was pretty fine. The center, you can see it's thinner than in the periphery. And the tomography, you can see the K from 69, it went to 57, improvement of vision minus 7.5 to +1. So we actually achieved a flattening of cornea as well by customization. So overall, when we do any additive procedure, it can strengthen the cornea. Stabilization of keratoconus is quite consistent in all the records, all the literature, and what we have found. And in few cases, they have been reported a flattening as well. So suppose you have a thicker cornea now, you can always, for visual rehabilitation, you can do a future topo-guided PRK. Suppose in case this ectasia still progresses, you can always do a cross-linking, and this time it will be a thicker cornea. It will be much safer for the endothelium, and you can change the final topography by changing the shape of the inlay that you transplant. So here again, I think a lot of work can be done, and we might be able to come up with some nomogram that how best we can make it very predictable. So for the time being, this is another management option for cornea surgeons when they are dealing with keratoconus, especially when the cornea is not fit for collagen cross-linking. Thank you so much.
Wonderful talk, Dr. Vikas. That was truly informative. I don't think there's need to put these patients on steroid drops for long, no, because placing a lenticule inside,
Yes.
infection issues are not there at all, right?
So you see, there are keratocytes, so we generally give them steroids for at least 3 months, and then watch in case for any reaction. So far we didn't see it, but you cannot rule out. So even in DLK, it's not that rejection will not happen at all. So you need to be careful. We generally give predfort for 3 months, and then loteprednol for at least 6 months. So total around 6 to 7 months we give them steroids.
Okay.
Because one question to you that. What would be your final goal? How are you targeting to visually rehabilitate this patient? Or rather, when you counsel the patient, how would you counsel the patient that what is your plan? What are you going to do ultimately?
So now, after we have done close to 60 odd patients, so we are sure, suppose the patient has good vision with glasses, and the patient is fit for cross-linking. There's no need to think about anything else. Only when the patient doesn't have good vision with glasses, we see that if with contact lenses, the vision has good. So we tell them that, see, you are not fit for cross-linking. We can go ahead with the additive procedure, which will stabilize the cornea. And for visual rehabilitation, we can always give you contact lenses. Sometimes, when they are, high myopes, those, and, cornea is very steep, we achieve some flattening also, but we don't promise that. I think at the moment we can promise that it will stabilize. That is for 100% sure. Most whatever we have seen so far. For making the patient visually rehabilitation, that will again depend on glasses and contact lenses. Regarding topo guided PRK, we have done in couple of patients, but I don't think that we got the result that we actually expected. So that thing, but you can always do it. So that maybe sometime later we might be able to understand it better.
Amount of astigmatism will be pretty significant, no? There's also a limit of how much tissue you can remove in topo guided. So I think
that's right. That's right. So suppose you are going at 130 microns, right, deep. So if you remove anterior 50, so you have close to 50-60 microns to play around. So you can ablate 50 to 60 microns. You have to take into account the compression that you will have. So those tissue you can ablate. Of course, you don't want to hit the new bowman layer that you have implanted in the cornea.
So I have one question for you, Vikas. There is going to be some attrition of the tissue because it's a human tissue over a period of time. So what is the longest follow-up you have?
So longest follow-up is 4 years now, close to 4 years. And in one girl who had very severe VKC as well as very severe K-conus, she had shown some resorption sign. But she had other eye which we didn't do anything because in a VKC patient it's very difficult to do cross-linking, and that eye went into high drops, and we have that planning for K-conus. In that, apart from this eye, we have not seen progression of ectasia so far.
But what about thinning of your lens that you implant?
So this girl, there was some thinning as compared to previous one, but rest of all, I think so far we are maintaining the same thickness. I don't know, maybe most of the tissue that we are using are 50 years plus. So these are the tissues, the donor tissue which are naturally cross-linked. I don't know if that is causing some beneficial effect, but so far, apart from this couple of these patients, we have not seen a resorption of lamina over a period of 3 to 4 years.
Okay, thank you. Paucity of time, we need to move on.